Good afternoon, everybody. I'm Laura McGahey, Executive Director of Sláintecare, and I'm delighted to welcome you to our webinar this afternoon, the first in 2021. Delivering the right care in the right place at the right time by the right team to ensure a quality, safe patient experience is a core Sláintecare principle. And there's a real commitment to this principle running through the 4 projects you will hear from today. I hope you'll find this afternoon's webinar both interesting and informative. And now I'm delighted to hand you over to your facilitator this afternoon, Dr. Gráinne Healy.
Thank you very much, Laura, and good afternoon to everyone. Great to see so many people logged on. Great to be back, 2021. I know there's still a lockdown, but actually there's so much wonderful work going on. This, as Laura says, is the first of our webinar, the 7th in the series, but the first for 2021. And it is, of course, part of our Learning Network event series. We are taking questions during the broadcast, so if asking a question or making a comment, please do indicate who the question's for, and we will make sure to get the answers for you. The chat button, the Q&A button, is at the bottom of your screen, and if you type in a question, it will come straight into me from there. Also, just to warn you that some of the videos we have this afternoon may be slightly out of sync in places, but we hope that that doesn't affect your enjoyment of the seminar. We're very happy to be delivering these webinars in conjunction with the Health Service Executive and with the support of IFIC, the International Forum for Integrated Care. Sláintecare is, as you know, about providing right care in the right place at the right time. And in these webinars, you'll hear how the projects funded by the Sláintecare Integration Funds and some HSE funded work is showing us best practice for healthcare reform and showing how many have adapted work practices and created improved pathways while responding to COVID-19. Much of this work is about quality improvement. It is, I think, important to acknowledge, as we are in lockdown 3, the challenges that so many of the projects we showcase here have faced and have overcome, from staff redeployment to actual COVID-19 cases to close contact case response. In fact, I want to congratulate all of the projects in these times who've continued to deliver or who've recently restarted delivery after a pause. You really are a credit to yourselves and to all of your colleagues working across the health service. We thank each of you for your commitment and dedication. This afternoon, our focus is on person-centred quality care, improving the experience of patients and service users. We have 4 projects doing innovative and effective change work, leading to improved quality of care, benefiting patients and service users to showcase for you today in the webinar. But before we start our webinar formally today, I'd like to take a moment to remember our colleague, Spencer Turvey, who passed away since we last met. His colleagues wanted to take a moment to remember him, and here is his colleague, Mike, to say a few words.
I'm Michael Fitzgerald, and I'm the Chief Officer for Cork Kerry Community Healthcare. Today, I just would like to remember the passing of Spencer Turvey, who was our clinical project coordinator working across the hospital community down here in Cork and Kerry. He passed away untimely on the 19th of November, and he's a great loss, of course, to his wife and his 3 children, as well as to his professional colleagues and friends. He was to the forefront here in Cork and Kerry in developing and rolling out the integrated care programme for older persons, and in more recent times in terms of the chronic disease programmes. Even up to the last day, when he was still working extremely hard, he was full of enthusiasm and excitement about rolling out these 2 programmes under the Enhanced Community Care Services. We remember him today and his sad loss to us all. Thank you.
Thank you very much, Michael. Spencer presented at our New Ways of Working webinar back in July 2020, and he had been working on the CHO Cork Kerry Urgent Ambulatory Care and Virtual Ward for Older Persons. The project was working to enable a move to a service model that is an alternative to emergency department attendance and hospital admissions. Delivered in a community setting, the project was making great progress in its delivery, and many older people in particular were and are benefiting from being able to remain at home while being assessed, diagnosed and treated with the help of a multidisciplinary team. The work of the project will go on, and Spencer has left a superb Sláintecare legacy with his work. We want to offer our deepest sympathies to Spencer's family, his colleagues and friends. May he rest in peace. As our theme today is on quality improvement, I'm delighted to bring you a short interview I did recently with Dr. Philip Crowley, Director of Quality Improvement with Hsc. Here is what Dr. Crowley had to tell us about quality improvement. So Dr. Philip Crowley is the National Director for Quality Improvement in the HSE, and we're very pleased that he's joined us this afternoon. Philip, you lead a national team that supports the health service to improve care through the application of a framework for improving quality. I know you also work part-time as a GP, and you've worked for many years both in the HSE and indeed you were Deputy Chief Medical Officer in the Department of Health for a period. So a lot of experience bringing you to this post. Tell us a little bit about the National QI team and what is it that you do?
Right, well, we have a national team that tries to support frontline services basically in improving care. And it, as you say, it applies a framework for improving quality that is built around 6 drivers that we believe are kind of address the fundamentals of developing a culture and an environment in which care can improve. Because it's one thing to look at improvement as a kind of like a technical fix for a technical problem. But I think many of the listeners today and the people involved in these wonderful projects will understand that improvement is also about creating an environment in which it's easier to work, where relationships are good, where teamwork prevails, and where hierarchy is not a dominant feature, shall we say. So a lot of what we do in QI is really about, first of all, applying a method for improvement. So having a method, but really working with leadership as well. And I know that leadership has been key to sustaining these projects through what has been a really difficult time. And I really want to commend the 126 projects for persisting. Whatever about persisting with the quality improvement project in normal times, to persist with one during the pandemic has been an extraordinary achievement by everybody involved. So really, really well done. But leadership has probably been key to that, I imagine. And your own leadership as project leaders and project members, team members, but also your own leaders, that they support what you're doing, that they understand it, and that they commit to it, and that they commit also to creating an environment where you can lead and where the people who you work with, everybody can lead. Everybody's an expert in their own area. So that's a lot of what we try and, I suppose, inculcate in the sites that we work in. Another branch to the framework that we would work on is also measurement. And I know measurement has probably been key to many of these projects, because I guess if we don't measure it, we don't know if we've improved it. And that's, I think that's a fundamental part of all improvement work. So we have a small group of people who work with teams, and we have resources on our website that can help people work out how to measure over time and chart improvement. And that really builds morale and builds momentum. And you can then show that to, if you're working in one service and there's a similar service next door, you can show them your results and say, look, why don't you try something similar? And that's really a key part of improvement as well. Partnering with patients is another, and service users is another fundamental building block of improvement. And we would urge everybody to, in any work that they do, to really see the people who use the services as their equal partners, and people with a lot of ideas about how it might better be done, and maybe ideas about what the problems are. They might see problems as being quite different to the ones that we see. And that's very worthwhile to engage with. And then partnering with staff. So it may seem like a bit almost like Nirvana-like that we'd be talking, and we do talk to the rest of the HSE leadership about a health service where everybody can lead, where we listen to all our staff. And we have projects in emergency departments where Porter has led one of the projects, Security Man has led another project. And these are with teams, with consultants on them, nurses on them, administration staff, multifaceted teams, but everybody is an expert in their own area. So that's another thing that we try and promote. And then I suppose the final kind of branch, other than having a method for improvement, is governance. So that's getting your improvement projects measured and on the agenda for the quality committee that oversees your service. So people are taking notice of what you're doing, and it's being governed. And if you're going awry, that you can get some help. And if you're doing well, you can deservedly get some congratulations and help in spreading it to your neighbouring services. So that's kind of the areas in which we work in. We've a whole load of resources on our website, which are freely available to everybody. We're increasingly putting digital content there, where there's an introduction to QI, there's a toolkit for quality improvement. There's lots of tools there that your teams may find useful as you continue your improvement journey. And we'd love to keep in touch with you and continue to improve.
Okay, and indeed, many of the projects that we've been showcasing in these webinars are demonstrating those 6 enablers, those 6 keys, and I think that's been very interesting to see the journey of quality improvement that many of the projects are having. What do you think are the greatest challenges for those who are leading quality improvement? What's the biggest challenge, or some of the biggest challenges in your view?
Well, I think it's the biggest challenge is achieving a state of optimism and belief that actually, we can improve things around here, that it doesn't always have to be this way, that the norms can be challenged, that we can do things differently. Getting our leadership on board is a challenge. I think time is a big challenge. I always think improvement is the kind of thing that we don't really have time for. But equally, we don't have time not to do it, because we don't do it, we'll never have the time. And improvement work can really buy us time by finding more efficient ways of doing things, ways that improve our morale, because we feel we're doing a better job. That's all any of us want to do. So I think time is a big challenge, and I think getting your leaders on board, sustaining the improvement is another big challenge. There's a lot of enthusiasm at the start of an initiative. And then, you start to embed the improvement. You see the improvement, and patients and service users are getting a better service, and they're involved, and everybody's feeling good about it. And then other priorities come along, and you can take your eye off the ball. You maybe stop measuring, and then you stop sustaining your improvement, and things go back maybe in a couple of years' time to the way they were. And that's always a bit sad. It all has not been wasted, but it is a pity not to sustain the improvement. And probably the best way is to keep measuring it, and then you'll know if things are starting to slip, and then you can reapply yourself to the task.
Yeah, and we've seen even with some of the projects, despite COVID-19, that they've actually outstripped some of the targets that they had set for themselves. I'm thinking particularly of some of our e-learning projects, and some of the projects who thought they'd have to stop going out into the community, but in fact the community have found ways of engaging with them. So we've seen some of those challenges actually being overcome, and in fact COVID-19 being an opportunity for some of the quality improvement changes that perhaps even this time last year we might have thought that's not going to happen. Can I ask you, in terms of Sláintecare and the 126 projects that we're supporting, but maybe even wider than that, Sláintecare and its push for right care, right place, right time. In your view, what would your hope be for the Sláintecare projects as they lead out on these change initiatives that they're seeking right across the health service?
Yeah, well, I would say, well, first of all, I wouldn't be loading a whole load of expectations onto people who've already done an extraordinary thing in actually delivering an improvement project during a pandemic. But if I had hopes for 126 teams that have gone to this kind of effort to make things better for their service users and patients, I would say that you keep improving things. Stay in touch with the National Quality Improvement Team in any way. Email us if you want any support on things. Keep on the improvement journey. There's always another nut to crack. There's always something else that bugs people that you'd like to improve. So don't ask for permission. Seek forgiveness after you've implemented the improvement. But do always test your ideas. It's because history is littered with great ideas that don't work. So that's why the model for improvement is useful, because it's based on this concept that you test your idea with a small number of people, and then if it works there, or if it doesn't, you modify it, and then you come up with an approach that will will work, and then you can implement it at scale. So yeah, keep improving, keep in touch with each other, keep in touch with us, try and become part of what we're trying to build, I suppose, which is a kind of an improvement army across our health services, where everybody feels they have the right to improve something, that we can give them some of the tools and skills to do that, and that they can get on and make their lives easier. Because if we can improve our work, then the people who come in to avail of the product of our work will get a better product. So I always think, improve things for our staff, and that will improve things for our service users and patients as well. So keep on the improvement journey. Start with your own team as well. Like, if this idea that, we don't wait for your leader to create, or whoever is your boss to kind of create the perfect environment in which improvement can thrive. Create it around yourself, with the people who work with you. Listen to every member of the team. Try and make everybody feel valued, and that their ideas for improvement in their area of expertise are just as valid as anybody else's. And keep in touch with us.
That's super. Philip, thank you and your improvement army, and thank you for all the work that you do. Thanks for joining us this afternoon.
Thanks, Gráinne, and thanks to everybody who's been doing this work. Fantastic. Well done.
And thank you, Dr. Crowley, for setting the scene for us as we look forward to having you with us later on in the panel that we'll have towards the end of the webinar. So today we have 4 really interesting and diverse projects to bring to you, sharing stories of work from the Sláintecare Integration Fund, all of which have a focus, I believe, on quality improvement and on improving the experience of patients or service users. As Sláintecare continues on its journey to ensure right care, right time, right place, these projects allow us to demonstrate what Sláintecare quality improvement looks like. Our first project this afternoon is called Hsc Health Passport for people with intellectual disability accessing healthcare settings in Ireland. This project aims to embed a standardised health passport for individuals with an intellectual disability who access healthcare services. The scaling up of the Hsc passport for people with an intellectual disability is being rolled out in Donegal and Sligo Leitrim. A patient safety and communication tool, this initiative seeks to ensure that the patient voice is heard in whatever health or social care service they interact. Niamh Wilson, the researcher on the project, spoke to me recently and explained what the project was doing, its impacts and benefits. Very welcome to Niamh Walsh. Niamh is working on a really interesting project, improved patient supports for people with intellectual disability, or in short, a passport. Niamh is herself a registered nurse who has worked in particular with prioritising those with intellectual disabilities, and Niamh is the key researcher and collaborator really on this project. Niamh, you're very welcome.
Thank you very much, Gráinne.
So let's start maybe, Niamh, with you just telling us a little bit about the project. What is the project about?
So the project is the Hsc Health Passport for people with intellectual disabilities, and the passport is designed to be an effective communication tool for people with intellectual disability to healthcare providers, people they meet along their healthcare journey, not just in the acute setting, but across all healthcare settings, be that from the consultant right down to somebody who might be providing them with their meal. It identifies areas of likes, dislikes, areas of need, areas of support, what's important to them. So it's a tool that provides effective two-way communication between the person with intellectual disability and the person providing the care to them.
Great. So a real passport on a journey then, as you say.
Absolutely.
And tell me, is it a physical thing that the person carries with them, or is it digital? Just talk a little bit about how it works.
So the Hsc Health Passport initially was developed as a physical document. It's an A4 size 6-page document with information using photo symbols and easy to read indicators of where the person can fill it in. They carry it with them like that. It's a passport. It's unique to them and they own it. It is not a patient held record of any kind. The person decides what is important to them and they input that into their passport, and they decide what information they share with the healthcare professional. it was further developed, and Sláintecare have enabled us to do this into an app, and we've achieved that, and the app is ready to launch. So the app is identical and replica to the hard copy passport. It will be available in the coming weeks, please God. We're almost over the line with it, through the Google Play Store and the Apple Play Store as well. The really important point about this Hsc Health Passport is that it is a patient safety tool. Good communication between people with intellectual disability, people with cognitive impairment or communication difficulty is really important to the health outcomes of a proportion of people in our society who disproportionately have poor health outcomes. So the research also will enable us to be able to identify those areas as well. So it's not that it's just a nice thing to do, it's really an essential component of how we provide care to people with intellectual disability, and that is meeting their communication needs.
Exactly. And also, one of the things that interests me in terms of the project is that you're hoping that the passport will facilitate healthcare professionals to make the required reasonable adjustments. What does that mean in ordinary language? What's a reasonable?
Well, I suppose, Grania, a reasonable adjustment is just that. It might be that we may allow extra time for an appointment. It might be that we have a space available for someone who finds, let's say, for example, a person with autism might have sensory issues, too much noise in an area, that we consider those things when we have read their Hsc Health Passport and we've identified areas of need that they have identified for themselves. They might identify that they don't like too much light and it might disturb their equilibrium. They might identify that you know, 1 or 2 persons maximum in a room, and we're in that space now with COVID anyway. But just to give you an example of some feedback that we've had from a parent who used the passport with her son in an emergency department setting within the last 6 months. She identified that her son, who had had a stroke when he was very young, he also had Down syndrome, that he couldn't have his temperature read on one side of his body. This was integral to his care at that time because he went in with a high fever. The doctor commented on the passport, and as Mum said, she was so wrapped up in his acute illness that she was able to spend the time previous to going into hospital with her son, filling in his passport. And what was really important for hospital staff to know, in an acute setting where you're worried about your son, he's very unwell, it might be the thing you might overlook or forget so she said the passport for her was a godsend in that regard. And the response that she got from the emergency consultant said that it was great to have that information that maybe you would miss in that interaction immediately, and maybe miss a possible.
And that's a great story in terms of moving now to an app where most of us go nowhere without our mobile phones.
Exactly.
So the mother could have her app and all the information could be there to share with the professionals. So that's a really good storyline around the benefits. So the project itself then has really allowed the passport to be developed. You were hoping to offer this to 400 people with intellectual disabilities. Has COVID impacted on how many people you've been able to sign up?
Absolutely.
Okay, so talk a little bit about that.
So Sláintecare, first of all, has enabled us to reach so many more people. Sláintecare has enabled us to develop the app. We wouldn't have been able to do that. And it has also has enabled us to make the team bigger because we've 2 new staff as a result.
Right.
In relation to the challenges that we faced with COVID, we took great opportunity from COVID. And from that, the demand for the passport increased. We to date have circulated over 1,200 hard copy passports as a direct result of the impact of COVID and the demand as a result. One of the things that we need to keep in mind is that the leading cause of death of people with intellectual disability is respiratory disorders. So with COVID, and we've done very well in this country in minding our people with intellectual disability. We've done exceptionally well internationally in that regard, and we really need to applaud ourselves for that. But Sláintecare enabled us, the Hsc Health Passport team, to circulate over 1,200 hard copy passports, and to develop the HSE app at an expedited rate as a result of COVID as well. Not only that, we've developed easy read materials for HSE comms in relation to cocooning, self-isolation, restricted movements. And they came to us, they seen the work that we did, they seen how easily readable the materials that we had were, and they asked us to develop their communications into an easy read format. But the wonderful thing about that opportunity is that it wasn't just for people with intellectual disabilities. It was for the general public. It was for people who might have a cognitive impairment, people who have literacy difficulties, and people with language barriers. So much so, Grania, that the International Protection Accommodation Services came to us and asked us, could we develop the self-isolation document into 10 languages. So that was converted into 10 languages. All of this under the umbrella of the Sláintecare initiative. So it absolutely, COVID is challenging, absolutely, but it gave us fantastic opportunities. Yeah. And subsequently, we've worked on the Pfizer BioNTech vaccine, and we have, as the Hsc Health Passport team, have developed the easy read materials for that, for the general population.
Well done, and that's so important, as you say, that, you know, if we target communication materials at people who have particular needs, actually we're covering so many more people of the general population. So overall, then, it seems to me you've surpassed some of the original aims.
We really have.
That you set for yourself. Well done. In terms of scalability and sustainability, what are the things that, is it scalable? Could this be available? I know you're working in CHO1, Donegal, Sligo, Leitrim, West Cavan, but, you know, is it scalable, and what would you need to make it sustainable?
It is absolutely scalable, and again, we have exceeded that as well. We've had contact from mental health services, cancer care services. We've had contact from people who work in long-term conditions, because they see the materials that we have, they see the Hsc Health Passport, and they see the potential for it across disciplines and across sectors. The success of this is that we keep people with intellectual disability at the core, and we work very, very closely with our intellectual disability advocates, Paul Gallen and Geraldine Rabbit. Without them, we cannot produce materials for people with intellectual disability without having them as very much a part of our team. So everything that we produce and everything that we consult on, really they get the final say on it, because there's no point in producing a document or materials if the people that it's intended for don't actually say, well, yes, we understand what it is that you're trying to do.
Absolutely.
So that's critical to the success of the rollout. We have reached services in all corners of the Republic, from Cork to Aris Atracta in the west, Palmerstown, St Mental Health and ID services in the southwest and in Dublin. So we've really gone far above and beyond, and we continue to do that with the support and the funding that we've received from Sláintecare. And again, we wouldn't have been able to achieve that without the support.
Great. And I know we're going to hear in a moment from the people directly, as you think, nothing about us without us. Absolutely. Is the principle that you've applied. And we look forward to hearing from those people who have really made your project the success so far that it is. Can I wish you all the best with that, Niamh? And we'll have, I think, more conversation later in the webinar about how it's going for you. So thanks very much. Great to talk with you. Thank you.
Hi, my name is Paul Gallen. Hsc Health Passport is great. It helps people communicate their needs to staff. We joined the conference, attended all students about the passport, and met lots of new friends. That was good also. The health passport has been made into the app. It'll be launched soon with the video starring Pip Pope and myself, the main star.
Hi, I'm Geraldine. I've been working on the Hsc Health Passport. We present it to nurses, doctors and ambulance drivers at their different national conferences During COVID, we also helped with the easy read documents to develop them. The Hsc Health Passport and app will help people with intellectual disabilities communicate their needs and abilities to healthcare staff, such as telling them what supports they need. I liked the work going around the country to different events.
So thank you so much for that, and great testimonies there at the end of that clip. Niamh, you're very welcome, and as I said, that was a really great conversation and great to hear from the two co-collaborators. Niamh, earlier we heard Dr. Philip Crowley speak about the importance of quality improvement to enhance patient experience. If you had to pick one key way in which your passport enhances the experience of those who use it when they interact with health and care services, what would that be, Niamh, in your view? Sorry, Niamh, I think you're on mute. No, no sound. Okay, we might try and come back to you at the panel stage to put that question and to get your response. Yeah, and also at the panel, we will have your colleague, Dr. Anne Gallen, who's also going to speak to us. So sorry about the technology there. Our second project this afternoon is Community Living Mental Health Recovery Coordination. This initiative seeks to further develop a peer mentor programme offering training to tenants and clients in the Greater Dublin area living with severe and enduring mental ill health. Let's hear from Nisha Cunningham, the coordinator, about HALE, an organisation working with homeless people, and their partners, and how they are going about delivering this service to a vulnerable group. Welcome to the webinar this afternoon. We're delighted that you could join with us. Nisha, I know you are the peer support coordinator with this project, increasing social inclusion of clients with mental ill health through expansion of the peer support programme. Before we talk about what you do, would you talk a little bit about who are the clients that you're working with in your programme?
Sure. So our clients are people who've experienced mental health difficulties. They come to us to HALE, which is an authorised housing body. So they've also had some difficulties around housing. So primarily the reason that they come to us is they have that dual experience. There's a very wide variety of mental health experiences that they have. So they could be from quite mild to quite serious.
Very good. And I know we'll be hearing some testimonials from some of the people later on. So that's great that you have that. So talk to me about the peer coordinator role in your project. What do you do and what's the value of it to your clients?
Sure, thank you. So I suppose my role within the project is to provide a framework, to provide a structure. The core piece and the core value, the biggest asset in our project here is its volunteers. We have 16 volunteers. So my role primarily is to support those volunteers, to build their capacity to deliver the service. And I suppose to gather the intelligence from our volunteers that we can really make sure our service is peer designed, it's peer led, and it's peer delivered. So that involves a lot of kind of training and capacity building.
Okay,
primarily.
so what does it look like then? If I am one of the people who's coming to you for help, I have had a history maybe of mental ill health, what do the volunteers do to help me?
Okay, so first we'll be quite careful about how we might match you up with a peer support volunteer. We'll want to be cognizant of maybe who you are as a person, your experience, your interests, and we'll try and get the right chemistry with a peer support volunteer. Our peer support volunteers then have worked face-to-face, by phone, on a one-to-one basis and in a group basis to provide emotional and social support. to support people to build kind of practical skills and capacities to maintain their own mental health. And the idea behind that is that our peer support volunteers are supporting their independence and supporting our peer clients to manage their own mental health.
So in terms of, the experience that people are having, I guess, one of the questions that people are asking about anything that's around peer support or meeting people is the impact that COVID has had on the experience, indeed on delivering the program. How has it been for you?
Sure. I mean, this whole project is around building connection and making relationships and providing support through that personal connection. And obviously that's been disrupted when we can't see one another face to face. In an ideal world, we would provide our one-to-one support and our group support together socially and have that personal connection. The group of volunteers adapted really quickly. We did lots of training very quickly and moved by phone to video call and online to support our peer clients. There's no doubt that the needs of the clients that we're supporting have escalated during COVID. Really? But likewise, our peer support volunteers have adapted
to meet that need. So what are the kind of outcomes that you've seen so far? I know your program isn't finished yet, but what are the outcomes you're seeing that you can measure and tell us about?
Sure. I suppose we have developed and trained work with 16 peer support volunteers. They're engaged, and our peer support volunteers are reporting a massive positive impact on their own lives and their own sense of maintenance of their own mental health. At the moment, we have 68 peer clients engaged. We have 44 involved in one-to-one support and 24 engaged, additional clients engaged in group support. So in terms of numbers, we've had 682 engagements on a one-to-one, and that's growing all the time. So as the months go by, they're increasing. In December, we had 176. In January, we're expecting that to be 200. So that's huge growth. And in terms of, I suppose, the impact on client social interaction and that decrease in isolation, our peer clients are telling us that they feel less lonely and less isolated, and that they're telling us that they feel more connected to their community as a result. They're telling us that they feel more confident since they started using the service, and that they'd recommend using the service. So we know we're achieving our first outcome, which is around the client social interactions and that decrease in social isolation.
Very good.
Our second outcome,
sorry, in terms of the peer support, so are these the people providing support, if it's peer support, are they people who themselves have struggled with mental health issues in the past?
Absolutely.
Okay,
and
that's interesting.
And we're so conscious of that, Grania, that our peer support volunteers have also that direct lived experience, and that's of a huge asset to our peer clients, because there's a level of understanding and a level of identification with one another, I suppose, that maybe not necessarily be met by, in a more traditional way, in a more traditional setting.
Yeah, very interesting. So this idea of the peer support, people who've they've walked the walk, they've talked the talk. So it's very much a relationship of equals, which sounds really, really good. The sustainability of the project, what do you think, in order to replicate this and maybe, have it around nationwide, what would you need to make that happen?
Sure. I suppose in terms of sustainability for us, key is our peer support engagement, retaining our peer support volunteers. So that means really investing in our peer support volunteers. That's key for us. Co-production is absolutely at the core of our project here. So ensuring that our peer support volunteers are supported and engaged and really with part of our organisation. So they inform our organisation and how the organisation develops. We would love to see the project expand. It's already exceeding its capacity, and at the moment we're providing a service in the Greater Dublin area, and we've already started to expand, and we've requests in from all over the place. So we're expanding into Wicklow at the moment, but the potential for scalability is huge. No matter where you are, you may have the experience of our peer clients. So the potential is huge, but core to, I suppose, that scalability and that sustainability is having that coordinator in place. Without somebody to coordinate the peer support volunteers and to build that capacity and to provide that framework for them to work within, it's just not possible.
Very good. So your role is super important, and we're so glad that Sláintecare has been able to support you to do what I think is one of the, really good example of right care, right place, right time for the clients who so badly need it. Nisha, thank you very much for your time this afternoon, and we'll talk with you later in the webinar.
That's lovely. Thank you, Grania.
So thank you so much, Nisha, to you and to your team indeed. Is Nisha going to come on with us? There she is. Great. Thanks, Nisha, for that. Nisha, have there been any learnings from the project? I'm sure there have been many learnings, but maybe one or two that you'd like to share with us now at this point.
Sure. We've had a really steep learning curve as we've moved through this project. This project is based really on that connection and relationship building and that person-centered approach that you mentioned earlier. So we really had to adapt our methods really quickly, and the models of peer support that we were working with, and how we could do that through technology and to deliver that connection remotely. So that was a huge learning, I suppose, for us as as staff, but also for our volunteers, and our clients as well had to be trained to come on board and to use those techniques. We had anticipated great benefits for our peer clients and our volunteers, but I suppose what we didn't anticipate, which was a huge benefit and a huge learning to us, was that added value that the 16 volunteers have brought to our organisation here in Hale. Not simply in terms of hours that they've committed, but in terms of having that lived experience and us being able to draw on that expertise. We can work with our team of peer support volunteers around their expertise, that lived experience, to really inform how our mental health supports work, and to really ensure that the services that we're designing and delivering are really based on something solid that can really improve people's mental health outcomes. For us, embedding that learning is key to the future of Hale. And we know that if we can do that throughout the organisation, not just in this one particular project, but throughout the organisation, in the mental health supports that we provide, that we can really have an impact on people's mental health outcomes, and particularly around maybe hospital admissions in the future.
Very good. Excellent. Nisha, we'll talk with you later in the panel discussion, but thank you much for that. Our third... Oh, sorry. Okay, we're going to have another piece from Nisha's project.
The role of a peer support worker or volunteer is, well, somebody that has their own lived experience within a mental health background, be it personally or maybe within a family. It's to meet people where they are, give them hope for recovery, encourage them to connect, have an identity out of the mental health kind of bubble, and to support and encourage people that recovery is possible, and to help them on their journey in any way that we can.
I'll tell you, these groups are really helping me to boost my confidence as a person, and I feel like a sense of belonging being in the groups, because it's a very non-judgmental groups that really help me to push past my boundaries.
With the Get Up the Catch-Up group every Friday morning, it helps me get out of bed and fights isolation, being able to link in with a group.
It's let me know that I'm part of the bigger framework, and to me that's very, very important.
The level of empathy and encouragement and the willingness of people to really listen, it's been brilliant. And I think everybody who has participated in the groups has definitely benefited from that overall sense of togetherness.
There's no judgment, there's no belittling, and in that people are genuine and real, and they, to the best of their ability, will respond to anything you share in a way that they hope will be engaging and life-affirming for the person concerned.
It's really added to my life.
And as always, the personal testimonies of beneficiaries and those who are using these services is very, I think, powerful to hear. So thank you so much for including those for us to share this afternoon. Our third project works with a homeless accommodation service to deliver outreach clinics by GPs called Inclusion Health Primary Care. flexible working for better health outcomes. Let's hear from Dr. Tadhg Lehane, a GP with the Thomas Court Primary Care Centre, about their project and the progress they're making. Lehane, you're very, very welcome to the webinar this afternoon. Tadhg, could I ask you to start off maybe by telling us a little bit about who your project is aimed at? I know you are dealing with those who are engaged in homeless service provision. So maybe talk a little bit about the issues and the problems about engaging that cohort and what your project is hoping to do with those people.
So thank you so much for having me, by the way. So just to explain, our project is Inclusion Health Primary Care. So what it specifically is kind of in the title itself. It involves reaching out to people who are disadvantaged or marginalized within society and bringing, in the spirit of Sláintecare, I suppose, healthcare as close as you can directly to them, to where they're living. What it involves is it's clinics in 2 different homeless hostels, catering for 3 different homeless hostels. Funded, as I said, by Sundial and overseen by Thomas Court Medical Practice, where I work, and DePaul, Ireland. And it's born out of a kind of very specific needs. So one of the hostels in which I work is a place called Sundial House Hostel, which is a hostel for up to 32 people. And everyone in that hostel will have been long-term rough sleepers for like 15, 20 years. And everyone would have entered into the hostel with a background of alcohol dependency. So, you know, pretty much the most marginalized people within society, give or take. And there's been kind of studies done in around that very specific hostel in the past by Dr. Clíní Callig of Inclusion Health in St. James's Hospital that identified that compared to the population, overall population, the average age in the clinic is people who are 58.8. Okay, so 58.8 is the average age of the clinic. And when they're compared to the overall population, they have equivalent health needs to people over the age of 85.
Wow. Okay.
The average number of comorbidities is over 6. And the really startling thing about people who are in that particular setting is it was estimated, I think it's between 2015 and 2016, that up to 2% of all hospital bed days in St. James Hospital were from that specific cohort of about 30 people. Considering that actual St. James Hospital it has a catchment area of 250,000 people, that is pretty staggering. Mm-hmm. So I suppose our intention is to reach out to these people, and if you're coming from a position of homelessness, I suppose there is a stigma attached to it, and there's also a stigma attached to addiction. And for a lot of people in that setting, they will have had negative interactions with healthcare. So what these clinics kind of set us up to do is to give us space and time to get to know each other. I mean, myself and the patients involved in a non-paternalistic setting, developing relationships of trust and respect, and letting them identify, along with myself, their healthcare needs, and empowering them to make decisions around their healthcare that may prevent their necessity for kind of acute setting issues. Stuff happening suddenly that can harm them, but actually getting in front of them, being proactive and planning ahead. Yeah. And I'd say it's being successful in that.
Very good. And I know from looking at some of the documentation around the project that you had hoped to have engagement with 200 patients, but in fact you've exceeded that number. What's the secret of your success around the engagement with these individuals who are, I think, notoriously hard to reach?
Hard to reach, yeah. So I think the secret is possibly not a big secret. And I suppose it stands to a lot of reason. It's literally just being there in a certain extent and being a human being around them. I know that sounds really simple, and when it comes to the idea of Sundial and delivering care that's inexpensive, well, that is pretty inexpensive, being a human being and being respectful and giving people time and space to talk. And I think, over time, and I mean, that does require time for sure. Mm-hmm. I mean, that's another secret ingredient. Is over time getting to know people and giving them space to talk about how they feel, and giving them respect in terms of how they feel about their healthcare. I think that's really, those things are really important too. Can I just say one more thing, just in terms of the other special ingredient is the overall staff within homelessness as well, particularly the nurses on site there, who are incalculable in terms of what they do as well, of course.
Okay, so I suppose what we're hearing then is that you're able to reach this vulnerable group, you build a relationship of trust, but also, I guess, if you're seeing them regularly over a period of time, conditions, you're able to detect things earlier, you're able to get an early input, and in that sense, you're also then resulting in, fewer people ending up maybe in emergency departments or needing urgent care. So that's a hugely important element, of course, of the Sláintecare plan, that close to home treatment and regular and stopping people from getting really unwell or really ill. And you mentioned COVID-19. How have you coped with, I suppose, or have you had to pivot to deliver the project during COVID? How has it affected the delivery?
That's really interesting. So it's affected in a variety of different ways. Again, I've a few colleagues in like infectious disease and stuff who would have signposted what this is going to be bad, it's going to happen. So at the start, we started educating our clientele within the homeless sector. This is coming, wash your hands, cough etiquette, and to prepare that maybe there'll be a bit of a lockdown. And again, I played a very small part in this, but the overall homeless sector, the outcome so far, and touch wood that continues, have been incredible.
Yes, I saw that.
So that's one small part of it. Collaborating with the likes of safety and making sure that we have very quick testing and isolation. That's happening all the time. It's incredible. I mean, I take no credit for it, but it's collaboration, and it certainly is a communication part that is developed over time, and we're all working together in that. One thing we've pivoted towards during this period of time was in some of the shielding centres in Dublin's inner city, and we've put, as part of our Sláintecare, I suppose, mission here, we have I've regular communication here, daily communication with the nurses working in there, dealing with homeless patients, and we've tried some video consultations, mainly phone consultations. We put aside slots within our timetable every week to try and accommodate anything we can, and we have a weekly meeting with staff involved there to identify, a bit like we're talking earlier, being proactive, identifying early needs for patients, and so we can get in front of problems. Now, it's not as straightforward as working in a hostel and doing cycles of care and stuff, but we have adjusted accordingly. But one of the, and a side note, one of the real things I did notice about COVID-19 is at the start, when it really, with the first lockdown, I myself am someone who's like type 1 diabetes. So I didn't know, is this going to be like Italy where can't get into ICU? So I actually worked from home for the first few weeks, and that lack of face-to-face contact, without having any negative impacts, thank goodness, it's so noticeable how different it is. And so for our clientele themselves, I think one lesson we really was kind of, I suppose, reinforcing for someone was, you got to be there. You have to be there face-to-face with the people we're talking about for a variety of different reasons. And I suppose that's a big lesson from COVID-19, is probably that we're doing something right in that setting anyway, and I think that's been very revealing.
And tell me, I mean, it sounds to me that this is, okay, it's in one particular area. It's Kildare West, Wicklow, Dublin West, Dublin South City, Dublin Southwest CHO7, and in partnership, as you mentioned already, with the Thomas Court Medical Centre and DePaul. But it sounds to me like it's a model of integrated care that really could be replicated in other places. Would you agree? And if so, what would be required to make that happen?
I would absolutely agree with this. So I think you start at what is the principle of what this type of care is, and it is bringing care as close to home as you can to people who are difficult to reach. As I said, it's low-hanging fruits because the benefits are near immediate, and I don't think they're kind of easy. It's just being around people and then being medical staff and doing what you're trained to do. So there's so many different types of communities in which this can happen. I think of, because I've taught a lot about this, of course, so anything from the Roma community, from members of the traveling community, even like I think of, I got lots of relatives and family and friends in a variety of different settings around Ireland. I know there's old folks group meetings that happen every day around the country. To go on and do an inclusion health clinic there, you'll get to know people very well. I think that's a real service for people. It's a real service, because a big part of this is actually empowering people to take on to make their own choices and around healthcare. And that is, again, a big principle around this. So in terms of things you might need, I think you need a space and a time, like a room. You might need a laptop. You might need a little bit of software to record things, maybe, but you could actually probably just record it by hand if you need to. But the way things have gone in Irish healthcare, I think that these are very easy things to do. And maybe a stethoscope and a blood pressure cuff and all the stuff that you think about. One of the big things, though, as I said, I come back to that I do think is really, really so beneficial in any settings is having nursing staff, in particular, who are enthusiastic and dynamic and work well in those settings. And I can't understate how important they are in that setting as well. And that is easier said than done as well. But I think that is something that
they're crucial. So maybe to conclude, how are you going about evaluating the project, and what are you hoping to be able to come up with at the end? Because it sounds to me that it is replicable, and it would be great to have the evidence base to be able to get that out there.
Absolutely. So there's an independent evaluation occurring at present. So we're hoping to have some results probably in the middle of this year. So it's qualitative analysis and quantitative as well. So it's I think in part it's independently, but it's assessing I suppose service users and how they've interacted with the project and people undertaking the project. I think ways in which we can also look at that evaluation are I suppose they aren't the perfect barometer, but the likes of engagement itself. I think that's a really good way of it. And that is, I mean, without going straight to the stats, that is apparent straight away. I mean, when we started in one of the hostels in Back Lane, which is a hostel with 62 people, we were getting 2 or 3 people a day. And now we're full from start to finish. And we're getting, I think the amount of repeat attendances is really important. And also evaluation, in terms of a means evaluation, part of this is about continuity of care. So people who leave homelessness do stick, we'll say, with myself. And I've so many people I can think off the top of my head. Obviously, I don't want to name names here. Some people off the top of my head who I'm in regular contact with as patients, as their doctor now, since they've left homelessness. And I think that's, again, it's a testament to this project itself as well, that people who for years have been maybe left a little bit outside of healthcare are being brought into the mainstream services and getting the treatment they deserve.
Yeah, and certainly as part of the Sláintecare, right place, right time, it sounds like this is a project that's really doing that on the ground. So look, thanks very much for your time. Very best of luck with the project, and we look forward to coming back to you maybe later in the year when you've got the evaluation evidence, and we'll have further conversation with you then. Thanks very much for your time this afternoon.
Thank you, and thank you so much. Bye-bye.
Thank you. So yeah, most interesting project, and I think we have Tig with us still this afternoon. Thanks very much for joining us. Tig, you spoke somewhat there about, running this kind of service for vulnerable, hard to reach people. I'm wondering if you want to dig a little deeper for us there around the challenges that you face in providing this service and how you're overcoming them with this cohort of client.
Sure, yeah. I mean, the challenges are probably very evident even in the title of the project itself. These are some of the most kind of hard to reach people in society. A huge portion of them are long-term homeless, maybe 10, 20, 30 years living on the streets, people with addiction issues, and people maybe with alcohol issues. Everyone will have experienced significant trauma in their lives, and maybe at present experiencing that trauma too. So, the challenges are both geographical in terms of literally being there in the place where they are, which is overcome, of course, with the nature of this project, which is very, very beneficial for them. But there's maybe a psychological challenge there in terms of connecting with people in this setting. A lot of people will have a well-placed mistrust of perceived authority from previous difficult interactions. They will have had difficult interactions with healthcare in general. There is a stigma attached to homelessness. And if you show up in a healthcare setting, oftentimes you may get treated differently to a person who isn't homeless. So I think how we overcome that specific challenge is getting to know these people, giving them space and time to communicate with me, to be understood, have their concerns heard, and for them to be heard, to know that they're heard, and know that they're seen. And people really come with you when they know that you are listening to them and are trying. And that is the foundation, the platform on which all our good healthcare outcomes have stemmed from. So I think that is the challenge, and that is the clear solution.
Very good. Thank you very much. We'll get back with questions for you in the panel tag, but for now, thank you very much.
Thank you.
Our final project presentation this afternoon, before we go to the panel, and we are getting lots of questions in, thank you so much for those, is the Community Mothers Programme, Prevention is Better Than Cure. It's a project aiming to create a standardised model for delivery and review of the Community Mothers Programme. This home visiting programme, delivered in 10 communities, supports parents in pregnancy and early childhood to care for their babies and young children, while encouraging them to look after their own health and well-being. I spoke with Susan Brocklesby, project coordinator, to hear more about the project and how it's going. But first, let's see a short piece about the programme featuring the mothers, the babies, and some of the team involved.
The Community Mothers Programme is an early years community-based home visiting programme for families with new babies. It is a programme where a trained and experienced home visitor visits parents from pre-birth to 3 years of age. The programme works with all families under progressive universalism. It represents the essence of Sláintecare in that it is the right care, which is the provision of information and support in a non-judgmental way through trusted relationships with the home visitor. It is also the right time. Engaging with families pre-birth is central to supporting the best outcomes for both child and parents, in fact for the whole family. This crucial window between 0 to 3 can ensure the early intervention and prevention that is central to Sláintecare. And it's the right place because it's delivered in the home. It's around the kitchen table or on the sitting room floor playing with baby. It meets parents where they're at. The consistency and responsiveness of home visitors empowers and reassures new parents or families.
I went through a really low point in my life. Didn't know where to go to or what to do, or couldn't find a way out, or I had total involvement, and I needed that help. And that's where I was introduced into the Mothers Programme. Absolutely, without this service, I would not be here today.
It's been a real help knowing on my days I'm struggling or not coping well that my community mother is only at the other end of the phone. It's just like having a friend that listens to everything and tries to direct you in the right way and helping you out as much as they can.
We have learned so much through this programme about the different types of play, such as the treasure chest, sensory play, and even classes such as baby massage. The pandemic has been quite difficult. Our contact Marion has always checked in on how I'm doing and how James is handling it, and making sure that James is still progressing.
The content of the programme is drawn from the National Healthy Childhood Programme, with a focus on infant mental health, breastfeeding, nutrition and weaning, supporting parents in their parenting role as they learn about their child's health, development and learning, and also supporting parents as they juggle their new parenting role with other pressures, demands or stresses.
The success of our programme is all down to relationships. Firstly, relationships with our team. Secondly, it's the relationship with service providers out there. In order to be able to work with families, we need to be able to engage with services. And thirdly, the most vital part is the relationship with the family.
For me, the key element at the core of our practice is taking the time to develop a warm, trusted and non-judgmental relationship with parents. It is this relationship that allows us to share the vital health promotion information and advice that we deliver.
At its peak, the programme was delivered across 17 sites in Ireland, providing a service to over 3,500 families. Today, the service is delivered by 8 sites, and one of these is a pilot service which commenced last year.
We are currently establishing the pilot in County Roscommon, and it's been an interesting experience so far because we don't have a national office as such to reach out to. We are literally learning as we go, but having said that, we're benefiting immensely from the experience of the other sites in the rest of the country.
These sites currently provide services to over 2,000 families and growing, with a new site in development. It brings the total number of site services participating in our development initiative to 9. Grown out of concern for the future sustainability of the programme, a mapping exercise in 2017 identified all the services in Ireland who had their origins in the Community Mothers programme. It was clear that without coming together and establishing a standardised model of delivery with national support, that the work of these programmes could go unnoticed and possibly also close.
The most valuable element of participating in the Sláintecare initiative is achieving what we couldn't hope to do individually as projects, focusing on best outcomes and best practice, and then gleaning the best of what each project does, working together and sharing our knowledge and expertise.
This new evolved programme, I think it gives us an opportunity to take on board the first 5 strategy and really pull together, to work together, to share information, share our expertise, to listen and learn from each other, and keep the family at the centre of what we do and what we do well. And I also think it really hones in on the whole concept of better outcomes, brighter futures for our children.
Moving from a volunteer to a paraprofessional approach has proved important in that the expectations and the associated training and skill set is such that has become now a professionally delivered service on the ground for families.
We bring to this a wealth of knowledge and experience in relationship-based working, which we hope to see embedded in the new programme. We now have been afforded an opportunity for training and development in outcomes-focused work, giving us an opportunity to develop evidence, data, which is qualitative and quantitative, which will contribute enormously to our future delivery of a responsive, needs-led programme for parents with young children in the community.
The Community Mothers programme is a really good example of joint working relationships between TUSLA, Hsc, the voluntary and community partners, with families and parents at the centre of the work.
The aim of the initiative is to establish an implementation plan as to how this programme can continue to grow and sustain. We are linking in with all national policy and service delivery stakeholders, and most importantly, we will be consulting and engaging with parents. We are hopeful that the outcome of our initiative will ensure the best quality services for parents are sustained and will have the opportunity to grow and develop across Ireland.
And we've just heard about Community Mothers, this standardised national model of programme development. Susan, a very interesting project. And I guess you touch on it perhaps a little, but you might like to say a little bit more about the impact that COVID-19 has had on the project delivery and indeed on Community Mothers more widely.
Yeah, absolutely. Well, the Community Mothers programme themselves have been extremely creative and innovative in how they've responded to the challenge. And, you know, from using obviously phone calls and Zoom calls to replace the home visits, they've even gone further. They've delivered groups through Zoom, infant massage, even mother-toddler groups and sing-along and storytelling. So they've certainly maximised their capacity in terms of virtual and communication and engagement. When the restrictions lessened, they still observed guidelines, and they were able to maybe drop gifts off to parents, such as massage oils for the infant massage classes, or packs of games and so on, and also maybe did things like walk and talk. So instead of actually a home visit, they brought things out into the open air and, maintaining social distancing, still did that walk and talk, because that face-to-face engagement is so central to the programme and the sustaining of that relationships. So they've certainly been very creative, including parents leading themselves in developing a co-produced cookbook in one area, where they all cooked with their toddlers and produced a recipe book in a particular area. So they've been extremely creative. For us as the initiative, we anticipated a lot more challenges than actually resulted. And in fact, it's probably been a benefit to our initiative, because we've been able to engage across the country more frequently, more intensively, using virtual communication. So we've been meeting fortnightly with the programs, as opposed to what we thought might be 2 or 3 sessions. And also with our stakeholders, we've been able to bring together and consult with stakeholders in health and well-being, child health, and with our colleagues in TUSLA. So we've been able to bring those people together in a much more efficient manner than if we had to travel to meet.
Great. Yeah. So an unexpected opportunity.
Yeah.
Great. And Susan, can I ask you about, sustainability and scalability? What are the plans? What are your thinking? What do you need?
So I suppose sustainability-wise, sustainability is at the core of the programme. It's why the initiative came together. In the 40 years history of the Community Mothers Programme, there hasn't been investment in programme development, in training and evaluation. And so really that was why the initiative came together and why we sought funding from Sláintecare. I suppose key to that will be the work that we're doing will provide a roadmap for the future for the programme, both at a national level in terms of what national supports programmes require to sustain, to grow, develop and continuously evolve, because all evidence-based programmes aren't static and they must continuously learn, develop and evolve. And I think that salutary lessons there for anyone involved in programme development or protocol development, especially with and having a central evidence base for it. So national supports will be essential, but also local supports, and we're developing an implementation plan which will outline the supports each site will require so that they can make the changes in line with our standardised model of practice. With sort of a key element of that will be data gathering to continuously evidence the outcomes that the programmes are looking to achieve.
Excellent. Great stuff. Listen, best of luck with the programme. Sounds wonderful, and all the mothers and their children sound like they're getting a good deal with you. So thank you very much.
That's great. Thank you, Grania. Thank you.
So yeah, great initiative. And as Susan mentioned there, you know, the Community Mothers Programme has been going for many years. And I suppose sort of a follow-up question, if Susan is on the line there, is just to ask you about, you know, the pre-existing Community Mothers Programme and how your project is adding value to it, and briefly the expected outcomes. You touched on some of them there, but maybe to give us a little bit more insight into the expected outcomes.
Yeah, absolutely, Grania. Thanks a million. So obviously programmes had developed themselves, but up until now that has been very much in isolation. So the real essence and added value of this particular initiative is bringing people together, both to share their learning, but also to develop and to grow together. I suppose, obviously, I mentioned in the video that there's no national support structure there to do that. And so through our work together, we've been able to harness that collectivity, and having someone like myself to be able to go and actually build linkages and learn more about national service priorities and align and integrate those with the work of the community mothers. I suppose you know, I mentioned there the programme is over 40 years old. One particular change we've actually added value that we've changed to make the programme more accessible to families of today's Ireland is to change the name of the programme. And so we'd be looking to move away from community mothers and towards community families, and embracing and making sure that it's accessible for all families. I mentioned, and it was mentioned in the video as well, about outcomes focused work, and that's something that we've definitely been able to add to the programme to date. In terms of in isolation, the groups themselves would have maybe found that more difficult to access training and supports and developments. So through that, we've built on from the original RCT research from way back in the 2000s, and developed 6 key outcomes for the programme for parents, which include increased breastfeeding, positive child attachment and relationships, positive parental mental health, and children developing positive mental health, positive physical health for the whole family, including things like sleep and nutrition. And obviously you heard from the video that the programme's uniquely placed to intervene at this crucial time, especially around weaning and introducing healthy foods and so on. So it's uniquely placed to address many of those more broad health promotional and physical health sort of outcomes. Also in terms of parents feeling more confident and supported, and finally in the earlier identification of additional needs. So they're the key outcomes that the programme will focus on going forward. We've developed our data framework, but we're just finalising a mechanism through which we can gather that data and information co-produced with parents, so that parents are also left with some information that's meaningful for them. And so that will then enhance our ongoing development development and evidence base. Yeah.
That's great, Susan. And not forgetting the baby massage. I love that element of it. I think it's really attractive to many mothers and babies alike. So look, thank you very much.
It's a real broker as well in terms of that relationship, because you can get down with mum on the floor with baby, and relationship can develop. So
brilliant.
Thanks, Grania.
Thank you. Thanks a million. So we're going to move straight into our panel discussion. Our panel this afternoon are Susan Bucklesby, whom you've just heard from, Dr. Ty Glahan, Nisha Cunningham, Niamh Walsh, Dr. Anne Gallen, and we're delighted to be rejoined by Dr. Philip Crowley. We have tons of questions coming in, which is fantastic. I don't think we get to all of them, but what I would like to do maybe is just go back to Dr. Crowley. Philip, if you're there, a lot of questions coming in wondering, you know, is there a network or a specific community in Ireland that people with experience of leading quality improvement can link into or access? So I'll maybe put that to you, and then we'll ask you to comment on, you know, the quality improvement elements that you've heard in the projects that we've looked at this afternoon. So over to you first.
Great. Thanks, Grania. Yeah, I mean, in relation to a community, there are informal communities, and there is one formal community we are a member of, which is the Q community, which is Q for quality, obviously. And it's a community that we've partnered with our friends in the North and colleagues in the UK. And it's really a great opportunity for people who want to improve stuff to become part of a community. And if they contact the quality improvement team, we'll hook you up with this community. And it's a community in Ireland and a community across the UK. So yeah, there are communities.
And in terms of what you've seen in terms of quality improvement, the work projects they're doing here, what's your take on them?
Oh, I mean, I find, you know, I don't know how everybody else is, but not all my days at work are great. So today is a good day, because you know, to hear what people are doing, it just I think it gives everybody a lift. It's been a tough whole year, and really for me, what these 4 projects exemplify, I know they're part of a much wider group of projects, is that with a bit of seed funding, and sometimes even without any funding, people in the front line just get up and do stuff themselves. And in a way, what my message to their managers is to just get out of the way, or enable, help people improve, but don't be in the way. So the ideas are all out there. The expertise is out in the front line. People know their own job. People know their own environment in which they're working in. They know the issues and the challenges. And like fundamentally for me, these projects have all been about social inclusion as well, which to me is, you can't have quality without equality. You can't have a wonderful service that a certain group of people can't access. That's no quality for them at all. So I think the fact that they're focused on equity, the fact that they're focused on service user partnership, and really empowering the people who we work with. So it's not all about us doing things for other people. It's a lot about people doing stuff for themselves with just a little bit of support, and people in difficult situations. So for me, quality is improving the service user experience, and these are all about that. So really wonderful projects.
Great stuff, yeah, a good day. I'm just going to go to Dr. Anne Gallen, who hasn't come in yet. And Anne is working on the passport initiative that Niamh described to us earlier on. I have tons of questions. We could spend the next hour answering questions, such as the interest in the passport initiative. But maybe what I'll do is, a number of them are about, you know, can the passport be rolled out to motor neuron clients, older people with cognitive issues? So maybe, Anne, you'd address that question first of all about, this does seem to be a really transferable, useful tool. Will you talk a little bit about that, because there's great interest in it?
Thanks, Grania, and thanks to everyone who's as interested in the Hsc Health Passport as what both Niamh Walsh and I are here in Donegal. I suppose it's important to say at the outset that the concept of a health passport is not new, but what's a particular priority for us within the Sláintecare initiative that we're driving here is to enable the standardisation of a health passport template, so that it becomes easily recognisable for healthcare professionals, thereby, I suppose, enabling its utility for other cohorts. The passport, yes, of course, can be easily transferable for other populations. And we have been invited into many conversations to date in regard to its utility, for example, for the elderly, for those with cognitive impairment, mental health, cancer and chronic disease, to name but a few. But lastly, I suppose I also want to say that within this passport, it is evidence-based. It's using the European Easy Read guidelines, so it can also be adopted as a patient safety communication tool for those for whom English is not their first language. And as already pointed out earlier by Niamh Walsh, Niamh and I suppose the Health Passport ambassadors, Paul and Geraldine, are already working with HSE Communications to enable, I suppose, its use for those with communication challenges. So yes, we welcome, I suppose, the interest in this work, and we welcome anyone to get in contact with us so that we can enable its scalability across the country.
Very good, thank you. I have a question back to Nisha and the work that you're doing. A very specific question about how long will a volunteer be trained prior to becoming a peer support person in your service?
Okay, so each of our peer support volunteers undergo quite an amount of training. They each undergo 8 full-day workshops, they're group workshops that they undergo together. And they're very much based on the education model, where it's based around experiential learning and drawing on their own experience. Context is everything within this kind of work, so it's really around drawing on their own experience. The time frame depends on often the demand, but usually it's important to give a gap kind of in between those sessions to allow for that information to be absorbed, for our peer support volunteers to have an opportunity to reflect. And I suppose each session builds on the previous in terms of they build on that reflection process for the next one. So ideally it's an 8-week process, one full day per week.
Very good. And just as a last question to you, I understand that your project has been recognised as a best practice initiative by DCU. Very briefly, tell us a little bit about that. It's quite an accolade.
Mm-hmm. We were so thrilled to have this project identified through DCU, identified for a couple of different reasons. One being how the organisation has integrated and supported volunteers to really lead the programme. This isn't a paternalistic approach. This is very much about our peer support volunteers being in a leadership role and leadership position and informing us as an organisation within that co-production process. And that's apparently quite unique. Credit really has to go to our peer support volunteers who have been out there and sort of modelled how conscientious and how committed they are, and have really through their work illustrated the impact that they can have. So it's through them really that we received that accolade, and we're so proud. We've been invited by DCU and we have delivered some training sessions in their certificate in peer support in mental health. And we hope to continue to be a model for kind of innovation and creativity within the peer support and mental health realm.
Great stuff. And a question, Susan, for you around a specific one again, Parents First. That policy initiative had outcomes a few years ago. Have those outcomes been included in the research work that you're doing?
So yeah, we've drawn together all both the Department of Children in terms of better outcomes, brighter futures. So our outcomes align with that, and also looked across in terms of both TUSLA and the HSE in terms of Healthy Ireland framework for healthy childhood and so on, and the National Healthy Childhood Programme outcomes, to ensure that our outcomes align with national policy, and have engaged with stakeholders as well to ensure that they fit as well. Yeah.
Great. And Niamh, I'll come back to you. We're running out of time here, but your microphone let you down early on.
I don't know, can you hear me now?
I can hear you perfectly, great. Thank you. So maybe just to allow you back in, if you to pick one way in which the passport enhances the experience of those who use it when they interact, what would that be?
I think communication the ability to be able to communicate their unique needs across to healthcare professionals and all healthcare staff who they engage with at any interaction. It is something that enables a two-way process. And it also helps staff to understand the unique needs of people with intellectual disabilities as well when they're in those settings. And this, you know, challenges many assumptions that are often out there. For example, diagnostic overshadowing, where a clinical presentation can be largely put down to the person's disability rather than actually the clinical presentation. And sometimes where communication really is lacking in that area. What is it this person is trying to tell me? So that the Hsc Health Passport enables that two-way process, which is really, really important, really important.
Great. And finally, back to you, Tig, again, in terms of the project that you've been delivering. I'm just wondering about, I know you've got an evaluation process that you're setting up, but I'm just wondering in terms of outcomes, you mentioned things like, you know, maybe fewer arrivals into emergency department. Are there one or two other expected outcomes that you just like to tell us about resulting from your project?
Absolutely, yeah. So there's a bunch of different outcomes, I suppose. So the basic level, it's improving health outcomes, and how we do that is maybe by preempting things before they escalate. So we have a variety of kind of new cycles of care tailored towards the type of patients that we have. So we have a alcohol liver disease cycle of care, we have a neurology cycle of care linked in with the neurologist within the hospital, we have a COPD cycle of care, but also, you know, adapting to each individual, hearing what their issues are and working with them. We've some of the project itself has led to people attending outpatient clinic appointments in a way they hadn't before. So we used to have only about 15% attendance at outpatient clinic appointments. Now it's about 60%, which is really good. That's a collaborative approach from everyone working in the hospitals themselves. And I suppose the ultimate endpoint, as you're saying, is the idea that, you know, we would have less of an actual burden on the hospital itself. So less A&E attendances, which we know is happening, and less inpatient bed days, which also we know is happening. We just need to get the stats on that now, but it is a very dramatic drop on all of those things. And most importantly, and through all of this, I think it's a theme throughout this, is it just an improved quality of life? Yeah. That, you know, people are happier, they have taken control of their own health in a way they hadn't before, and are valued, and people know they're valued. I think that's really important. Very good. And on that point, we'll draw things to a close. I want to thank each of our guests today. Well done, all the great project work. I want to thank all of the panelists, each of you for the work that you're doing. Philip Crowley for setting the context at the outset and joining us again in the panel. Finally, we look forward to bringing you further webinars in the series throughout 2021, and hopefully by year end, we may even be able to have face-to-face panel discussions. Imagine that, guys. Travel out to meet project deliverers again in the real, as my grandson says. When are we going to see each other in the real? In the meantime, may I wish each of you a successful 2021, and thank you for the great work you're doing, showing quality improvement and innovation in action as you deliver Sláintecare and improve our health and care service and patient outcomes. Meanwhile, thanks to all the team here who helped produce this session: Rosaline Harlan, Muriel Farrell, Lindsay Dre, Ingrid Doyle, Erica Kinsella, Suzanne Lynch, and Tom Dukes. You can watch the webinar back or recommend it to your colleagues. It will be available on the Sláintecare website, and do send us your feedback. The questions we didn't get a chance to answer in the webinar will hopefully be posted to you in the coming days. So for me, Gráinne Healy, stay safe, wash your hands, and hold firm until next time. Thank you, everybody.